You'll know when you have a wild woman. She'll practice her craft without boundaries. She is truly autonomous. Her loyalty is only to the family she serves. She will not allow herself to be held back by a system she didn't create.
This podcast is for the birth keepers who want to grow and change, who are open to learning through self-reflection and supportive community. We are creating a space to explore without judgment. We are remembering we were born wild. Hello, everyone. Welcome back to the Born Wild podcast. I'm your host, Sophia Henderson, and today I have with me Dr. Stuart Fischbein, also known as Dr. Stu. Dr. Stu, for those who don't know, is an obstetrician who spent decades advocating for physiological birth, supporting families choosing breech, twins, and VBAC births outside the mainstream system. He has worked closely with midwives for over 35 years, attended hundreds of out-of-hospital births, and co-hosts the popular Birthing Instincts podcast. Known for his evidence-based, women-centered approach, Dr. Stu has dedicated his career to restoring common sense and compassion to maternity care. Welcome, Dr. Stu.
Thank you, Sophia. Thanks for having me on and giving me an opportunity to speak to your audience.
Yeah, thank you. Will you take us all the way back to wherever the beginning is for you? How did you get to where you are today?
Well, I'll try to do the abbreviated version, otherwise it would take up too much of our time. because it's an interesting tale. I had no interest in medicine when I was a young kid. I wanted to be a forest ranger or a marine biologist. I went to college, about my third year in college. Some of my friends were going pre-med. I was a biology major. I had a Jewish mother, so I didn't really have much choice, and I decided to go pre-med, and I got into medical school at the University of Minnesota. And if people understand how that works, the first 2 years are almost all classroom and lab, including anatomy lab, and then the second 2 years are almost all done on the wards. You have certain things that are requirements like surgery, internal medicine, OBGYN, pediatrics, and then you get electives like ear, nose, and throat, dermatology, neurology, radiology, and you get to pick some of those too. And I came off a rather depressing rotation on hematology oncology. And my next rotation was OBGYN, and I was up at night. Instead of pushing chemotherapy or dealing with seizures or things like that, I was catching babies. And I thought this was the greatest thing. Again, you're young, you're naive, you don't really know what you want to do in life. You don't think about liability or hours or pay or anything like that when you're that age. You basically do what entices you. And one of the things I really liked about the obstetric profession was longitudinal care. There are only three professions really in medicine that have that. That's internal medicine, family practice, and OBGYN, where you take care of somebody over years and years and years. Most other specialties, you might deal with their ruptured appendix and then you never see them again, or fix a broken arm and never see them again, or you could be a pathologist or a radiologist and really never see humans at all. And that's not what I wanted. Plus with OB, you got to do a little surgery, you got to do a little internal medicine, a little psychiatry, a little endocrinology, and of course you got to catch babies. So I made that choice. I matched my residency program in Southern California at Cedars-Sinai Medical Center, where I moved there with no intention of staying in California, just spending my 4 years there. But our residency was a very good residency program back then. It was a different era in medicine. We were affiliated with LA County USC Women's Hospital, which in the early 80s was the busiest hospital in the United States, doing about 22,000 births a year, which if you break that down is about 65 babies a day. And I was on for 4 months there every other day. So you can count and do the math. And so I got to see a lot of pathology, and I got to see a lot of breeches and twins, which were not considered pathology in those days. They were just variations of normal. In fact, we sort of kind of drew straws about who gets the lady in room 6 who's got the breech baby, because we wanted to have that. We wanted to have that experience. Came out of residency, was very medically trained, and didn't know anything that I know now. Thought that I knew everything, was soon to be enlightened. My enlightenment began because I had the good fortune of being approached by the local midwives in SoCal and being asked to take their home birth transports. And I have to backtrack for just a second and tell you that, I said medicine was a lot different back then. And when you came out of residency back in the early 80s, you had to build your own practice. So you covered emergency rooms, you covered other doctors when they were on vacation, you assisted them in surgery, you maybe worked at free clinics. And so one of the things I saw when the midwives approached me was not that I thought home birthing was a good idea. I saw it as a way to generate revenue for myself because I was building a practice. So I didn't go into it with the idea that this was the smart thing to do. I just want to say that because nowadays doctors come out of training and almost all of them get jobs working for an employer, They're paid a salary, they work a shift, and this will probably permeate our conversation today, but when you are working for someone else, you don't necessarily put in the same effort that when you're working for yourself. And we'll see that doctors become more sheep than shepherd. And in my generation, the doctors had big egos, that's true. They didn't always know what they were doing, and they did a lot of things that were wrong. Maybe we'll cross some of those today as well. But they did have an interest in their own clients because they knew them. They had been three of their children, and they had taken care of other things about their families, and they did their surgeries and their cancer and other things. And it was always the same. And if someone called you at night, you knew them by their first name, and you knew them, and you knew their husband's name, and maybe even remember their kids' names. As different when you're on call now and you're just taking a phone call from a perfect stranger. You don't treat people the same. Ideally you should. It's golden rule and all that, but you generally don't treat people the same when they're outside your line of sight. Like you treat your family probably better than you treat your neighbors, and you treat your neighbors better than you treat somebody on the other side of town, and you certainly treat somebody on the other side of town probably better than you treat somebody in another state or country.
Yeah, it's like relationship-based care. Yeah.
Yeah, it's just human nature. You have limited space to take care of everybody. You can't take care of everybody. You can't be crying for every person who is starving or dying or got fired from their job, or you just can't. The human mind isn't capable of that, at least as we stand now. Maybe someday we'll evolve to that point. Got off track. Anyway, so I worked with midwives for about 10 years, and then I realized what a good thing they were. And I was encouraged to start a collaborative midwifery practice in the hospital. We went to a different hospital because Cedars did not allow midwives to have privileges in those days. And we, for 15 years, had a collaborative practice. We called it the Woman's Place. And there were 2 or 3 certified nurse midwives and 1 or 2 doctors during that period of time. And the midwives took care of all the normal stuff. And the doctors like me took care of the problems. If a woman had an ectopic pregnancy, I would take care of that. If a woman needed prenatal care, the midwives did most of that. If you needed an ultrasound or a surgery or a breech or a C-section, then I would take care of that. If a woman needed a pap smear, the midwives did that. If she had an abnormal pap smear, needed a colposcopy, I would do that. Mm-hmm. And so I was dealing with the things that I was really good at, and midwives were dealing with the things that they were really good at. And a collaboration between the two of us had really good outcomes. And I will say that because, our C-section rate for our group was 7%. And in the 90s, when this was going on, the average C-section rate was in the high 20s, maybe 26, 27, 28%. We're now up to like 34%. Mm-hmm. So we were doing something right, and our outcomes were good, and our patients were happy. But here's the problem. The system doesn't care about those things. And we were making people in the system uncomfortable, whether they were uncomfortable because of our outcomes or whether they were uncomfortable because we were doing things that made the anesthesiologists, the pediatricians, and some of the labor nurses uncomfortable, like breeches. Like our moms didn't want epidurals, so there's no money in it for the anesthesiologists. Our babies wanted to go home, 4 hours after they gave birth. Pediatricians didn't want to come in, and they were uncomfortable not giving them vitamin K and not giving them hepatitis vaccine. And so eventually, after 15 years, they found a way to sort of get rid of us. It's a longer story. So I left that on the encouragement, again, of my midwife colleagues and some wise advisors, and I started doing home birthing. And I worked with midwives in collaboration. I never did it without them because I'm a guy, and I am an obstetrician, and I had guy obstetrician energy, and it took me a while to sort of become the person I am today. And I never can get rid of all of that, but I always worked with midwives, and we ended up having really good results, and I got braver, and I began to say, well, if I can do breech in the hospital, why can't I do breech at home? And then twins, and then things like type 1 diabetics and hypertensives, and trying to change the environment for those women that were in my community. And then I got old, and I got tired of being on call, because I'd been on call for myself for almost 40 years. And it disrupted my personal life, my social life, my sleep. Not that you get called every night. Birth workers know this, but you go to bed every night not knowing if you're going to be called. And that just kind of that cortisol and stuff wears on you. And I just felt be healthy. And so I stopped clinical practice. And in order to feel I could get away from LA and wouldn't be called at night, I had to get out of California anyway. I was just tired of California. And so I moved to Southern Utah, where now I do some meetings and consults on Zoom, on virtual meetings, and I speak at conferences, and I go around the world, and I teach my 2-day reteach breech and twin seminar, where I teach breech and twin skills to somewhere between 15 and 24 attendees on a full 2-day seminar. And I've been doing the podcast now for 13 years. Liz joined me in 2017, and we've been together now. I can't hardly believe it's 8 years that we've been together. And so that brings us pretty much up to date on the abbreviated version. That still took almost 10 minutes.
That's okay. The thing that always is hard for me, because that sounded like an ideal situation. Midwives take care of normal, hand it over when it's not, it's a little more complicated. And the thing is about the money making of the hospital, because is it true? I looked this up a long time ago. 50% of hospitals' revenue is maternity. Because in my mind, if they lose that, how could the hospital even like stand to function anymore? Because the problem is when we need a hospital, not even related to birth, but when you are in a car accident or you need the hospital, you need it. And so we don't want hospitals to go out of business, but we also don't want them to be like acting as a business trying to make money off of births that don't really need it.
I don't think that's true. I think that a lot of hospitals think labor and delivery is a loss leader. They actually lose money on normal labor and delivery, but it develops goodwill for the hospital. If you have a baby at the hospital, your feelings about that hospital used to be really good. Now I think there's a lot more emotional and even physical trauma and coercion that's being used, and people are waking up to that. But I don't think so. I think the things that make money are the higher tech things, like cesarean section will obviously make more money for a hospital than a vaginal delivery. A baby that goes to the newborn intensive care unit is a excuse the term, goldmine for the hospital. So the hospitals will find reasons to put babies in the NICU. Interestingly enough, Sophia, in the last 15 to 20 years, the rate of NICU admissions has almost doubled from a little over 5% to about 9.8%. Now, I'll just say this openly. People can obviously disagree or agree, but there can be no good reason for that, because either they're finding reasons to put babies in the NICU just because they can generate more revenue, or our outcomes are getting worse in the hospital and more babies need to go to the NICU. Neither one of them speaks well of the medicalized birth model. So I don't think it's a moneymaker. But about the money that you said, it's important. If midwives took care of all the normal things and OBs just did the complicated things, then OBs and hospitals would go out of business. Their labor wards would close, and OBs would have a problem because you need the normals to help offset the cost of running a hospital like that. Because we need the hospitals for appropriate inductions and C-sections and preemies and placenta previas and other problems that can happen. We need them for those cases, abruptions and some twins and breeches and things like that. If we didn't have them, we'd be in trouble. And that's why we have maternity care deserts in the country now, because even small hospitals that used to stay open for 30 deliveries a month can't do that anymore, because of fears of liability and overhead and costs like that. So they're shutting down their units, making women have to drive 50, 100 miles to find a labor and delivery unit that's still open. And if we decided that midwives should be taking care of all these normal pregnancies, and a lot of them should be done in birth centers or at home, then the hospital's maternity units wouldn't be able to keep their doors open. So it is a real dilemma, because the hospitals are not doing birth well. And we can go through some statistics to back what I'm saying. Everything I say, I can sort of back up with data, but I don't know. Sometimes in an hour and a half podcast, you don't have time to do all those things. The hospitals aren't doing very well. And so a lot of women would be better off not going there. But culturally, you have a positive pregnancy test, and the first thing you think about is what hospital am I going to go to? What OB am I going to pick? And that's just because we've culturally indoctrinated people to do that over the last 100 years. That was an intentional propagandizing and gaslighting of the American public to believe that pregnancy is an illness and a disease and needs to be treated medically and pharmaceutically. And so they vilified midwives and they vilified naturopaths, and they changed it from being a normal function of your body to being pathology that needed to be managed. And these are the kind of terms that drive me crazy when you hear terms like, we won't allow you to do that, or we need to manage your labor, or things like that. The language defines how we treat women, and it defines how we perceive pregnancy. I mean, if I can go on, when you go to the hospital and you're in labor, you're treated as a patient. You're asked to sign patient forms. You're told to go put on a hospital gown. You're put in a bed. Where do sick people go when they go to the hospital? They go into bed. Where do laboring women labor when they're at home? Hardly ever they're in bed. In the hospital, it's the center of the tension. It's the center of the room. And you have to get in bed, and you have to have the monitors on, and you're treated as if you are about to explode. And we've come as a culture to believe that. We now have 3, almost 4 generations of women in this country who have no knowledge of what natural birth is like. And we have no physicians who remember it anymore. All we have are the traditional midwives, because even midwifery schools now are becoming very medicalized. And we can't lose that. And I admire my colleague Bliss, who's going around the country right now with doing a project called At Her Feet, where she's archiving the stories of a lot of these granny midwives so that we don't lose their history.
Mhm. Yes, I've been listening. It's so good. Will you speak a little bit about before you started working with midwives and like what you were taught about birth, like physiological birth, and then examples of like what informed consent, as you were talking about, looks like in the hospital versus like what you saw midwives do. And you mentioned a little bit about like high risk and the things that you supported even at home and like what is high risk?
Okay, well, in the hospital, when I first started out, I was very medicalized and I didn't know any different. If you live in a world where everyone speaks Greek, then nobody knows Spanish. All right. So that's a weird analogy. But if you only know medicalized birth and you only see birth that way, you don't know anything about physiologic birth. So you asked about physiologic birth. I didn't know any, didn't see any.
Mm-hmm.
Those of your listeners who've watched Business of Being Born, still sort of the Bible of the current birthing is, they interview these 3 residents and they ask them, how many normal births have you seen? And they all look at each other and they go, none. I'm paraphrasing, but that's what they say. And then you have Marcin Wagner speaking, may he rest in peace, a mentor of mine, who said, if you want a natural childbirth, the best thing you can do is to stay the hell out of the hospital. That's a quote. We were not taught anything about physiologic birth. And everything about the way the hospital treats somebody in labor is anti-nature. It's anti-mammalian. You would never do to your laboring dog what you do to the laboring human female. And we know that. And everybody instinctively knows that if the dog's in labor, you leave her alone. And you don't take away her food and water. And you don't turn on bright lights. And you don't have loud noises. If little kids are running around the house, you tell the little kids to leave the dog alone. Or you send them outside. You don't disturb the mammal that's in labor. And yet everything that we do is the opposite of that. So there was no physiologic birth. I was the guy, and again, this is composite memories, but I was the guy dressed in the full hazmat suit, putting your legs up in stirrups, probably the worst position to be pushing in labor, but it was the standard position and nobody knew anything else, and that's what we did. Washing off your bottom, possibly with betadine, which is a sterile solution, taking blue drapes and draping them over your legs. Was I doing this to protect me or the mother, or was I doing it to protect the room or the furniture? I don't really know.
It's just what you were taught to do.
And then likely cutting an episiotomy as the baby's crowning, and then catching the baby, not waiting for the baby to spontaneously rotate or turn. Once the head is out, automatically pulling on the shoulders. If there's a nuchal cord, I'm trying to reduce it, get the baby out. I immediately fumble at the table with the sterile table with all the instruments laid out like a surgical thing. And I grab these 2 clamps and I would clamp the cord as fast as I possibly could, because that's what I was taught. Would you do that on an elephant? Would you do that on a dog? Would you do that on a horse? No, but we do it on a human being. And we clamp the cord and we cut the cord, or maybe we'd hand the scissors to the dad. That might be the token effort. They'd cut the cord. We'd show this beautiful baby to the woman that she just delivered, and then we walk it and set it down on the opposite side of the room in a warmer so the nurses could do unnecessary things to the baby. And I did that for years. And among many other things, I'm sure I induced women for being overdue. I'm sure I induced women for suspected big baby. I'm sure I did unnecessary C-sections, knowing what I know now. I can't be mad at myself then, because who I could be mad at is the people that trained me, and they didn't train me and to know that there are other ways of doing things, but they didn't. So that was sort of my experience. So my informed consent was very skewed, right? And this is the problem with informed consent. First of all, I don't give informed consent. I give information. The woman gives consent. You can see my T-shirt there. Physicians for informed consent. You give information, and then the woman decides to give consent or refusal. That's her choice. So I give information. Now, what information did I give them? Well, I only gave them the information that I knew. So the information I gave them was biased and skewed, as it always will be. Even today, if I see people information, I'm going to skew my information, but I'm going to freely, openly admit that I have a bias. Most of my OB colleagues don't even know they have a bias. They just think they're preaching ACOG guideline, good work, But if the work was so good and the guidelines were so good, how come the outcomes are getting worse? And there's no deeper thought than I'm doing what I'm told, and this is what I'm told. And by the way, since I'm an employee, who am I to tell my boss that I'm going to do something different? I'm going to get yelled at or lose my Christmas bonus if I do.
And you're taught that you only did a good job explaining if everyone picks the same choice after
Correct.
you're done.
That's correct. And by the way, there's a basic tenet of medical ethics that's the opposite of that. And that it says, given the same information, it's not reasonable to assume that 2 people will come to the same conclusion. And yet we were expecting our women to just do what we told them to do because we were so authoritative in our white coat knowledge that we knew what's best for them. without any consideration for what their fears are, what their life history was, what their future plans were about having more babies. None of that stuff even entered into the conversation because we were never trained to do that. I credit the way I talk now, I would say 90% to midwives and 10% to my parents. To be curious, to be that annoying kid that doesn't just say, okay, I'll do it, but often says, why?
Mhm.
Why are we doing that? That doesn't make any sense to me.
Mhm.
But I didn't do that, because residency is 4 years of indoctrination. You just want to get through your days. Your days are long. They're tired. They're tough. And so informed consent was biased and skewed. It's not possible, Sophia, to give true informed consent because that would take too long. I mean, basically, you'd have to read a package insert to somebody, and nobody's going to do that. Okay. So you give what I call, well, I forgot the term now, but it's like real informed consent or practical informed consent. And that's what you should be giving. And you should be giving both sides of each thing that you're talking about. But what's too often given is skewed informed consent.
My goal is that when I'm talking to my families, that they have no idea what I would choose out of those options. That the way I presented it makes it sound like, oh, I actually don't even know what she would choose. So that I'm not like biased leaning one way or another.
Yeah, I mean, ideally, that's the way it should be. Again, the system gets in the way of that sometimes because doctors don't have time to give, or nurses don't have time to spend 20 minutes giving informed consent, especially if things are moving fast or there's a problem. But they should. And these things should all be discussed way ahead of time, as much as possible. And then you asked briefly about high risk. High risk is something that I take dear to my heart because, again, it's a use of language that is really inappropriate. Because high risk does not mean what you think it means. High risk is not a number. High risk, I've concluded, is whatever makes the doctor or the health system uncomfortable. They're just repeating things that they've been taught or told, or they made them uncomfortable. There is no reason that a woman who's 35 years old is high risk just because she's 35. If she develops diabetes or hypertension, then she might have a higher chance of a problem. But I want to say something really important here. A higher chance of something happening does not mean it's high risk. It just means a higher chance than someone who doesn't have that issue. But high risk, we need to individualize our care because what you think is high risk, I might think is low risk. Somebody may think 1 in 100 is high risk. Another person says, well, that's a 99% chance it's not going to happen. I'm okay with that. And so it shouldn't be one size fits all, yet it is one size fits all. And I love to give examples of this sort of thing. So because I love breech birth, let me just give this example. People talk about breech birth being dangerous vaginally, and therefore all breeches should have a C-section. But they don't counsel the woman about the downside risks of C-section. So I would ask this question: what's riskier, having a vaginal breech birth or having a C-section for that breech and then wanting more children? Now, everyone in medicine is going to say a vaginal breech birth is riskier. Well, the risk of a vaginal breech birth having a worse outcome than a head-down vaginal birth, according to the Royal College of OBGYN, which is England's college, is 1 extra neonatal death per 1,000 deliveries. So modern obstetrics would have you think that we need to section 1,000 breeches to save 2 babies, but we're not going to section 1,000 head-down babies to save 1 baby. So we're sectioning 1,000 women to save 1 baby. But then now this woman wants to have another baby and say she gets pregnant too early. Well, they're going to tell her, oh, because it's not been 12 months or 18 months or 24 months, you have a high risk of uterine rupture. Well, if I would have had a vaginal delivery, it wouldn't have been an issue. And what is the risk of uterine rupture? And we can go through that too, or not. And what is the risk of something called placenta accreta or other placental attachment disorders? And that's high. And what if she wants a 3rd baby and she was sort of coerced subtly into having a second C-section because she was told that having a VBAC is now high risk. And now she's got 2 C-sections. Mm. And now she's going to have another. And maybe one of these pregnancies, she actually does rupture her uterus and she does have an injured baby. What's the risk of that happening? Or a placenta accreta where maybe she needs a hysterectomy at the time of her delivery. What's the risk of that happening versus the extra 1 in 1,000 of having a baby vaginally by breech delivery? No one can give you those numbers, but they can't be significantly different. They're probably worse. What's riskier, giving birth to a big baby or your doctor's concern that your baby might be too big?
Yeah.
Well, they're going to say you're giving birth to a big baby. You could have had a shoulder dystocia. Next baby, we might have to induce you early. But really, your doctor's fear of a big baby is probably going to lead to more interventions and more problems than most women who give birth to a 10-pound baby.
Fear of it versus the actual reality.
But one is labeled high risk. The other is labeled standard of care.
Yeah.
Think about it. Again, my obstetrical colleagues, they're in the matrix. They do not think outside of it. And I had an interesting conversation with a maternal fetal medicine doctor recently, and I asked why they do these things. And she said something that it never really occurred to me because I didn't think of it this way, but she said that the biggest fear of an OBGYN is not a neonatal death. It's not maternal morbidity. It's a brain damaged baby, because that's a lifetime of care and expenses. And those are the big judgments. We just had one here in Utah. I don't know what's going to happen to it on appeal, but they offered, I mean, the judge or jury verdict came back $960 million on a brain damaged baby. So what can you do to avoid a brain damaged baby? Well, you can do a C-section at 39 weeks. You don't care what happens to that baby's microbiome or that baby at age 2. You don't care what happens to that mom's recovery, that mom's depression, that mom's breastfeeding rate, that mom's memory of her birth and satisfaction years later. You don't care what happens in subsequent pregnancies to that mom or those babies in the future. You only care about not having a bad outcome with the baby now. And again, bad outcome is only defined by what happened in that immediate postpartum period. Because again, if that baby has childhood asthma or adult onset diabetes or some other autoimmune disorder because its microbiome was messed up with because of the way it was born, that's not the concern of your delivering obstetrician. But it
I
should
thought
be
you were going to say live baby in a bassinet. I was waiting for that.
Well, that's my slogan. And yeah, that is my slogan. Thank you for bringing that up. That's the only thing that matters. It's mean, maybe, but it's true. And how do I know it's true? Because look at any paper on obstetrics. What are the outcomes? The primary outcome is always neonatal death or neonatal morbidity. It's not what I just said. It's not how did the mom do? It's not how's the mom's psyche. It's not how did the baby do at age 2 or 5 or 10. None of that matters. All that matters is that number. So that's how we are trained to think in residency. And if you never experience anything outside of that box, you live your entire life in that box.
Yeah. It's not whole person care. As soon as the baby is over in the warmer, they've done their job.
Yeah, because now the baby belongs to the pediatric department. As opposed to a midwife model where mother baby are a dyad and should never be separated.
Yeah.
Why is the baby over there? Why is the baby in the nursery?
Yeah.
Why are you giving my 1-hour-old baby shots in its thigh? Why are you doing that? Did nature design babies so poorly that only man can step in and save them? And if that's the case, then how come we're not saving them? How come we're not? I mean, I'm not talking about 100 years ago or 200 years ago when we didn't understand germ theory or antibiotics or washing our hands between the cadaver lab and doing a vaginal exam with your bare hand. Yeah, I mean, where women died of puerperal sepsis and things like that. You know, people can exaggerate. But over the last 50 years, we've seen rising interventions and tech and treatments, and we have not seen any sort of commensurate improvement in outcomes. So what are we doing and why are we doing it? And I can tell you it's power and money, always power and money.
Can we speak a little bit to like breech, twins, VBAC, and just your experience with like the safety, the risks, like reality versus the fear of it? And what are like the biggest barriers that prevent families from accessing the type of care they want for their breech, VBAC, and twin babies?
You know, I feel like I'm playing T-ball here. You're just like putting a little ball on the stand so I can whack it. Yeah, because this is my bread and butter. Never intended it to be when I first started out, but breech and twins have become something that I'm really well versed in. I have published papers on it. I do teach this subject. Let me clear up one misconception right off the bat. VBAC should not be included as a triad with breech and twins. VBAC is just a vaginal delivery. It requires no special skill. If you know how to catch a baby or not, even if you're just a woman doing a free birth, a VBAC is just a birth. So there's no special skill required. Whereas breech and twins, to do them properly and support them properly, it's good to have these skills because every now and then you're going to need to use them. So those are different. How women are counseled is unfortunately how doctors are trained. And in the late 20th century, 80s and 90s, breech began to fall out of favor. I don't know exactly why. I was just coming into training in those days, and breech was considered normal when I was at County Hospital. And we, again, like I said, we loved doing them. And of course, we didn't have all fours positioning and we didn't keep hands off. It's the minute that we could get our hands on the baby's bum or feet, we just did a breech extraction. That's how we were taught. It was still probably better for mom and baby than having a C-section for breech. A lot of it was unnecessary, but that's how we were trained. Again, things are trained. It's harder to get good training now because you can't do certain things that we could do back in the early 80s. from a human rights perspective, that's better. We're better off. But from a training perspective, we're not. But breech became out of favor. And in 2000, a paper came out that sort of codified what doctors wanted to see happen. Again, this is not science, by the way. This is a very poorly written paper that had a lot of flaws in it. It should never have passed peer review. And yet, not only did it pass peer review, but it became the sort of the benchmark for how we're going to do breeches, which is we're going to section them all. Mm-hmm. And so it stopped being taught in training programs around the world, stopped teaching breech delivery. Yet breech delivery in the literature, even to this very day, the current literature that comes out usually supports properly selected term breech vaginal delivery by a skilled practitioner in the hospital setting. They're not going to support it in the home setting because no one does them in the home setting except midwives and people like me. And I was the first person to ever publish a study on home breech twins or breeches and twins. But you just don't see that. So the skill disappeared. And so when women have a breech baby now, they're faced with this dilemma and they're scrambling in the last few weeks of their pregnancy at a time when you should be nesting and resting and enjoying this and looking at baby clothes and having baby showers and having fun and doing things. You're scrambling and you're nervous and you're scared because the advice you're getting from your doctor is that having a vaginal breech birth is dangerous because they're giving you we're going back to biased informed consent now, and you're being told all the dangers of that without being told the dangers of the C-section or the dangers of future babe pregnancies are related to the C-section so that you can make an informed decision. And so breech skills have disappeared and women are running out of choices. So I would tell anybody listening that even before you're pregnant, but certainly by the time you're early in pregnancy, you want to ask these questions of your provider. You want to ask them, like, do you do breech delivery? And if they say no, you could look at them and you could say politely, well, why not? And they'll say it's dangerous. Well, actually, doctor, it's really not dangerous. And, the term breech trial was a flawed paper, and the Promoda study and there's a whole rack of them in my brain. I don't want to list them all, but all these studies incurring more recent studies, much larger in scale, showed that there was no difference in outcomes with breech versus vaginal head down babies. But, again, most people aren't going to do that. Most people aren't going to confront their doctor. But if you don't check it out at the beginning of your pregnancy, you might be faced with this. 3 to 4% of term pregnancies are going to be breech, and you're going to end up being told that you need to have a C-section. And you might have been planning for this beautiful hospital or home birth, and suddenly the rug is pulled out from under you. So you've got to plan for that ahead of time and find a skilled breech practitioner. The Breech Without Borders website has a search function that you can look for breech practitioners in your community, and you can find them. And if you can't find anybody, you may have to decide, you know what, I need to cross state lines. I need to relocate to Phoenix, or I need to relocate to Oregon or someplace where I can have a breech vaginal delivery. Because many of the states that doctors won't do breech delivery also pass laws lobbied for by the doctors' organizations to prevent midwives from helping you either. Why would they do that? They think they're the arbiters of safety. They're not. Just look at their model, look at their outcomes.
I know, I always laugh that Oregon and Washington moms, it's safe to have a breech baby, but California moms must be different. Their breech babies must be different because we're not allowed to have them at home here.
No, the medical lobby is just stronger in California. Right. Yeah, that's why. And then with twins, is the same thing. Most of the world literature on twins says that if twins make it to term and they don't have any of the problems that can come up with twins, which are more likely to happen, preterm labor, premature rupture of membranes, certain types of twins, thing called twin-twin transfusion syndrome, other things like that can happen with twins. Growth restriction is more likely in twins. Part of that is because they're misdiagnosed, because they're using singleton growth charts for twin babies in the second and third trimester. They should not be doing that, but these charts are built into the computers and the ultrasounds that they're using. So that rather than actually have to plot it by hand and see that, your baby's growing fine on a twin growth curve, but it's below the 10th percentile on a singleton growth curve. Therefore, we're going to call your baby growth restricted. And we're going to do all these protocols and tell you we have to bring your babies out at 34 or 35 weeks. And they can spend 3-4 weeks in the NICU, and that's okay because NICUs are great and all that stuff. And you can tell I'm sort of bathed in sarcasm here.
What do you consider preterm for twins?
Probably below 35 weeks. If and when if I would have had someone in labor at 34 and a half weeks and say the first twin was breech, and I knew if I sent them to the hospital, the only choice they had was a cesarean, I might have supported them. And then if the babies were having a little struggle afterwards, then the babies could have been transported to the hospital. But babies at 34 and 35 weeks are not going to require immediate respiratory assistance almost ever. They're going to have a little bit of maybe rapid breathing. Maybe they're not saturating their oxygen well enough after an hour or two, or they're working too hard to breathe. And so you take them in. It's not like the 26-weeker that might need immediate intubation and surfactant in their lungs and other things like that. That's not what we're talking about. Talking about term breeches, term twins, excuse me. But term twins beyond 35 weeks, those twins should be delivered vaginally if twin A is in a stable longitudinal lie, whether it's breech or vertex. The world literature supports breech first twin delivery. ACOG and OBGYN residency teaching programs and hospital risk management lawyers do not. You just have to decide which data and which advice you want to follow. And the success rates are very high. When you have a skilled practitioner and a mom who trusts her body, you can do really, really well. Right now, unfortunately, over 95% of breeches are sectioned in the United States, and over 75% of twins are sectioned in the United States. And if you look back 50 years ago, those numbers were under 5 or 10%. So did pregnancy become more problematic over those 50 years, or did doctors become less skilled and more liability conscious over those years? And their liability, as they believe, is from the bad baby, not from a mom who suffers a terrible complication from an unnecessary cesarean. When I say these things like terrible consequences, these things are also quite rare. So I'm saying them for effect to counteract the hyperbole that comes from the medicalized birth side about the risks and scary things. Birth is not scary. It can, like anything else, become scary. Skiing is not scary. If there's an avalanche, well, it might be for you. But if there's an avalanche, or if there's a blizzard, or if one of your skis falls off or something, yeah, it can become a problem. But it's not a problem just because you're skiing.
Yeah.
And it's not a problem just because you're pregnant with breeches or twins. Or singletons for that matter, singleton head down babies for that matter. Pregnancy is not an illness, and midwives taught me this. Trust nature's design. Doctors don't trust nature's design. So instead, they insert their own interventions because they don't trust Mother Nature. And they don't care that their interventions cause problems because they're comfortable with those problems. They're comfortable with a baby not tolerating an induction and needing a sort of an urgent C-section that they caused. But if it happened without them causing it, that makes them more nervous. Hope that came out okay. I talk about these things a lot. So sometimes I know what I'm saying, but I'm not sure that I'm saying it in a way that listeners are getting it. So hopefully everybody's understanding what I'm saying.
Yeah, I think so. One of the questions I had about VBAC is, but what about VBAC after 2 or after 3 or with special scars or myomectomy, or like there are some moms who have these situations where like, is it still just another birth?
It's called individualizing care. And again, in the algorithmic medical model, often because doctors are no longer solo practitioners anymore, they work for a company and a company thinks it's mitigating its liability by having policies. And so they're going to say, if you've had 2 C-sections or more, you can't have a VBAC. That's not how we should be counseling people. We should be looking at their history individually, looking at their desires, looking at their future planning. Do they want a 3rd baby and a 4th baby and a 5th baby? And maybe if we do a 3rd C-section on that woman, we're putting her at more risk because she wants a 4th and 5th baby. Maybe we should ask those questions. And would they low transverse C-sections? And what is the risk? Because again, what I counsel you on the risk might be different than how another doctor counsels you. Because I'm going to try to be as honest as possible, and they might be giving their information to skew you down the path toward repeat C-section. Partly because they're told by their bosses that they don't do VBAC after 2. So you have to somehow talk the woman into surrendering her desire for a VBAC after 2. When actually what you should be saying to her is, my system doesn't support VBAC after 2. You might want to consider trying a different doctor's office or a different hospital, or I know a doctor in the next town that is supportive of that. Why don't you go have a consult with him? That would be a very ethical thing to do, because doctors are under these pressures too. They can't, if they go against their group or their hospital's policy, they could find themselves in a lot of trouble. And partly because of the system now, the doctor who may tell you that you can have the VBAC after 2, even if the group doesn't really want to do it, might find that he's not on call when you're in labor. And a doctor who doesn't want to support VBAC after 2 is the doctor on call. And then everybody gets angry and pissed. So then that doctor might tell you, well, maybe we should induce you on a day when I'm on call. Mm-hmm. But then you're undergoing an unnecessary induction, which increases your risks of rupture and of needing another C-section simply because you're going in an unnecessary induction. So you can see the quagmire that modern obstetrical care is. VBAC after 3 and VBAC after multiple more than that, Again, there are certain risks of the scar separating, which is called dehiscence, not rupture. Rupture is a terrible word because it conjures up this image of a tire on a 18-wheeler blowing out on the highway. I mean, we always see all this rubber on the highway, and it's like, I've never seen, where does that come from? And then one time a few years ago, I did see a tire blow out on the freeway.
Wow.
So now I know where it comes from. On an 18-wheeler, it blew out. And the guy just pulled over. That's why they have 17 other wheels.
Because they got enough wheels.
And that's where it comes from. But that's rare. Most dehiscences don't result in horrible outcomes. So it's individualizing your counseling. And I would say that the midwifery model is much more geared to that kind of counseling than the medicalized birth model is. Women should not settle for a birth model that doesn't suit their needs just because they have an insurance card that says they need to go to this group or this hospital takes my insurance, so I'm going to go there. All of your listeners have probably by now heard the wedding analogy. And just in a nutshell, for your wedding, you spend all kinds of money and you plan everything. Plan the venue, you plan the invitations, you invite people that you love to come. You pick the food, you pick the color of the napkins, you pick everything. And for your birth, which is the other most important event in most traditional women's lives, again, I'm not excluding the idea that winning a gold medal or getting a promotion at work or finishing your law degree aren't huge events. But for most women, when they're on their deathbed, they're thinking about their wedding day, or maybe not, but they're thinking about the birth of their children, and they'll remember those. And for your wedding, you spend all these things, and for the birth, you just abdicate that responsibility to a third party. And so the joke is what if you had wedding insurance and when you got married, it was all covered, but you didn't get to pick the venue. They invited people to your wedding you don't like, and you couldn't have the chicken, you had to have the fish. And nobody would do that. And so we need to change the way we think. We've been culturally indoctrinated, as I said earlier, to be emotionally and physically separated from birth and from death. We've sterilized them in our country. Most people never see a birth in their life, and most people never see someone actually slowly, quietly fall asleep and pass away. People used to be born and die in their own home. And the modern medical and mortuary industry took care of that. And not so much the mortuary industry, the hospital injury. The mortuary would be there no matter what. So I misspoke about that. But the nursing home industry, all those sort of things, the depersonalization of that has affected us all. And we would be a much better world if our children saw their siblings being born and you had seen your siblings being born and your mother was telling you stories about her home births as opposed to making you nervous because she had C-sections because her OB told her she needed them. And now there's a bit of cognitive dissonance in her that if you have this home beautiful vaginal delivery, she's going to feel worse about herself and her births. This is human nature. I mean, I wish we were all more mature than that, but these things come out. We get emotional about these sorts of things.
Yeah.
So it's about individualizing care, and the current system doesn't allow for that to any major degree. So that's why women, for this event, seek out somebody who's going to give you the time of day. Go and interview physicians, and if they don't look you in the eye, if they're rushing you out the door, if they're rolling their eyes when you ask certain questions, don't stay there. You're the consumer. You're the employer. The doctor is your employee. Turn the tables on them. The hierarchy should be this way, not this way, because they work for you. We've forgotten that. And again, we should be very personable to them. We need to be very understanding of the pressures that doctors or nurses are under. There's no question there, but that's a pressure that occurs of their own making. And they could change it. It takes courage to stand up against that sort of tyranny, but they could change it. They could either leave the system and start something new, or they could band together and approach their administration and say, this policy banning VBAC or not breech delivery, this is not ethically sound, and we need to do something about it. We need to bring Dr. Stu or Breech Without Borders to our hospital so we can teach the nurses and doctors who are interested about breech delivery, because we had a surprise breech that came here last year, and we had to push that baby back up inside and do a crash C-section on the mom, and we hit the uterine artery, and she had to have a transfusion, 30 more seconds, and that baby would have been out vaginally. It's a skill that OBs should know, and they're not. And again, the fault lies with the training and the organized medicine. They're so interested in certain things, the organized medicine is, and not the things that are going to help improve outcomes. Right.
Well, I think you have such a unique perspective because it's one thing for midwives to speak and say this, but you've lived through being that person in the hospital and then having the group practice in the hospital with the midwives and then stepping outside. You've kind of touched a little bit of every area of care. And so I think it gives you a unique perspective to speak on it and like the way you've grown.
Yeah, it does say something that we think that having a degree makes you smart. But it doesn't. Wisdom doesn't come from degrees. Some of the dumbest people have multiple degrees, propagate the dumbest policies and the dumbest things. I am humbled by the fact that I am speaking to you today because not of my residency training program, not because I have an MD, not because I was board certified in 1989, not because I'm a fellow of the American College of OBGYN. All right, I'm associate now because I'm not board certified anymore. So that's a meaningless thing, but I'm not a member of the American College of OBGYN. That means nothing. My wisdom and knowledge came from midwives. Some were CNMs, some were licensed midwives, which are also called CPMs. Some were traditional birth attendants, had no licensing whatsoever, had no formal training whatsoever. They did apprenticeship training, which, by the way, was how every trade was taught for hundreds and hundreds and hundreds of years.
I can imagine some of your families that you worked with were also some great teachers as well.
Well, yeah, I mean, well, yes, I don't want to ignore the fact that the women who trusted me to be their practitioner taught me great lessons in life about courage and about stamina and about trusting their bodies, because I was not taught to trust a woman's body. Yeah, the beautiful stories I read on, there are really bad things about social media, but there's some really good things about social media. And reading some of the stories of like twin home birth is got an Instagram account that I follow, and stories there are just beautiful. And it's just designed to make other moms who had C-sections for their twins feel bad. I know a mom who had twins who had a beautiful twin home birth with mono twins. Okay. And she was kicked off Facebook group because mono twins are treated very medicalized in the birth world. They're hospitalized early on. Babies are all come by section at 32 weeks. They're in the NICU for a month or month and a half. And none of that is actually necessary if you look at the literature. But that is the standardized way we were taught. And most doctors, once they're taught something, find no incentive to look elsewhere. And we did look elsewhere. And this woman went to 37 and a half weeks, had a vaginal delivery of mono twins. And during her pregnancy, and wanted to tell her story afterwards to her Facebook group, and they kicked her off because it was too painful for many of the women on there. They didn't want to hear it.
Everyone was trauma bonded. Yeah.
Trauma bonded. That's a good term.
I didn't coin it.
No, I know you didn't. And right now, a lot of us are trauma bonded. Okay. So
Yeah. Well,
what else?
Will you please leave contact info so listeners can reach out to you? I'm curious for you to leave some information on if you do consults with either birth practitioners or families. And then also, do you have like cheat sheets that families could buy off you for like if they need to bring it to their practitioner to talk about why they feel this is a safer option for them?
I don't really have a cheat sheet. I have a form that I wrote for information for parents under hospital duress. So when you're getting threatened with coercion, like Child Protective Services, or we want to take your baby to the NICU and you don't think your baby needs to go to the NICU, I do have a sheet on that. People can just reach out to me and I'll just email them that response. The way to reach out to me is through birthinginstincts.com. It's my website. And on there is a bunch of tabs. One of them is called Work with Dr. Stu. And that's where if you wanted a virtual consult with me, I have two tiers on that. I have just a one-time inquiry, and then I have a more detailed one, which requires me reviewing your medical records. So sometimes if you have complicated cases and you want me to look at your records, and sometimes I get a record from Kaiser or something, and your one birth is 300 pages. It's insane. So there's that. And then I also have a thing on that for birth workers for, I think, $1,200 a year. $100 a month, basically. You have a all access membership where you can reach out to me, not for emergencies, but it's if you get an ultrasound report back and you want my opinion on that, or you get some labs back and you're not sure about that, or you have a woman who's got a funny history about maybe she had a blood clot after a car accident and you want to know, does she need to be anticoagulated? Those sorts of questions.
You're like, not emergencies. I'm not on call again.
Correct. You can't call me expect me in the middle of labor to respond to something.
Yeah.
Because that's my whole point of not doing that anymore. My podcast is the Birthing Instincts podcast. It's on all your apps, Spotify, iTunes, Apple Podcasts. The website for that is birthinginstinctspodcast.com. And we have a Patreon membership group there, many different tiers of membership, depending on what level you want. There's a free level, and then there's all the way up to medical fuckery level. We've got some funny names for the levels where we do a monthly peer review. We do a monthly Q&A. This does a monthly village prenatal visit where you could come and you can sit in on a prenatal visit with Bliss once a month. We also do extra content that we put in there. So that's our Patreon. You find that through birthinginstinctspodcast.com website. Instagram, I'm at Birthing Instincts, of course. That's everything is Birthing Instincts. I don't do X and I don't do TikTok. I've been encouraged to do that. I just don't have the bandwidth to do them. And my assistant, who's really good, probably just doesn't have the time either. But I think as audiences sort of drift more toward X and TikTok and away from Instagram, Instagram's still fairly popular. Facebook the younger generation doesn't really use Facebook that much. Pregnant women rarely do, or not as much as they used to. Maybe we'll expand in that way. I've written 4 papers that have been published, one on home twin birthing, one on home breech birthing. They can be found again on my Birthing Instincts website. You can click on a link there, open access, free. I wrote a book years ago called Fearless Pregnancy. It was first printed in 2004 when I was still a hospital-based physician. The subtitle is Wisdom and Reassurance from a Doctor, a Midwife, and a Mom. And we have each wrote little sections about different topics. It's still fairly poignant. To this point, certain chapters like the genetics chapter are obsolete because it was written long before we had the non-invasive prenatal testing, the gene stuff that we can do now that wasn't there then. But still, it's a good, more fearless read than the book that tends to tell you what to do when you're expecting, which is not a book that I would highly recommend. Yeah. Did I miss anything? Oh, and I teach my seminar.
Your seminars that we've attended. Love.
So that's also the events page on my website. You can find where I'm coming to next. They've been very well received. You're not going to walk away from a seminar as a breech expert, but you are going to have the confidence and courage to know what to do with a breech that might show up as a surprise, which anybody who's practicing obstetrics is going to have some of those, and knowing what to do is really important. And it might give you the confidence to then go out and start supporting women with breech and having a mentor to do that. That is sort of where I really want to see things go, is the teaching. I'd like to see it get back into residency training programs. Breech Without Borders is the only other one. If Breech Without Borders and I weren't teaching breech delivery around the world, nobody would be teaching it. There's nobody doing it other than us. No academic institution is trying to bring breech back. There are some that have breech services on their hospitals, and that's great. No, but they're training 5 residents a year. I mean, they're graduating 5 residents a year to do that. You're not going to be able to spread it that much. But I would tell women who have a breech that need a hospital birth for any reason, that find a breech center. There are them in the country that are doing them. You can find them. And I think that and then I have interests in the MAHA movement. Peripherally, I'm not directly related. They haven't really done much yet with maternity. There is a group called the MAHA Moms Group, and I would encourage moms, if you're interested in trying to bring health back to pregnancy. And obviously, our immune system and our immune health begins in the womb, and we need to do what we can for that. And I hope that in the coming years, the Kennedy and the Trump administration will put more effort into pregnancy. Right now, they're busy with vaccines and food and maybe geoengineering and glyphosate and those sort of things, which are obviously fluoride in the water, obviously very important stuff. But ultimately, we need to stop poisoning our moms. And we need to remember that how we give birth matters. And our immune systems are set up in utero, but are really established shortly after we're birthed, and with our gut and our gut bacteria and our gut flora. And obviously, we're not doing well. And all you have to do is look at the rise of chronic disease in children. And you can blame all kinds of things for that, but certainly the rise in C-section rate and the rise in use of antibiotics, while has had some benefit, has certainly not been beneficial. I mean, there's an organization I don't have much respect for called the World Health Organization. Everybody's heard of it. But they did say that the C-section rate in Western countries should be around 10 to 15%, and that anything above that, there's no benefit to it. That outcomes might improve slightly with a C-section rate of about 10% over a C-section rate of, say, 5%. But once you get beyond 10, 15%, there's been no benefit to it. Yet there isn't a country in the world that has a C-section rate of 10 or 15%. And there are many countries in the world that are approaching 70 and 80% C-section rates with no concern for what that is doing to our species and to these mothers and then their offspring, those future babies, both boys and girls. If they haven't experienced the trials of labor and the exposure to mom's oxytocin and hormone cocktail, will it affect them somehow? Will they have more attention deficit disorder? Will they have less attachments to people? Will they be more autistic? Will they be able to go into labor when they're pregnant? We have no idea what we're doing, and we're doing it anyway. And I think that it's time, we have to stop. We have enough history of doctors doing stupid things because they thought it would be good, or maybe they thought it would make somebody money. From heavy metals in babies' teething powder to spraying DDT on children to thalidomide to diethylstilbestrol to the use of Cytotec in VBACs, to giving potentially SSRIs to pregnant women without any knowledge of it, and certainly to the whole vaccine program and ACOG full all in on giving 5 different vaccines 4 different vaccines, 6 different antigens to pregnant women in utero with not a single safety study, not a randomized, double-blinded, controlled safety study. And clearly there's evidence now in the literature of detriment to the COVID vaccine and giving it to pregnant women. And yet the American College and most hospitals and doctors and pediatricians are still all in on giving pregnant women and newborn babies and all these things without any real knowledge of its safety. And clearly our outcomes are not getting better because of it. There was just a paper released this week. Aaron Siri presented it at Ron Johnson's hearing in Washington, where they did a study at the Henry Ford Hospital in Michigan. I'm not sure if it's a hospital or a medical center, what it is, but they looked at babies over a many year period of time, and there were 18,000 babies in it, children in it, excuse me. And I think 16,000 were in the vaccinated group and 2,000 were in the completely unvaccinated group. And in every measure of health that you can think of for children, the unvaccinated group were healthy. Now, we knew this ahead of time. There's been a book called Unvaxxed by Robert Kennedy and Brian Hooker. Paul Thomas put out Vax Facts, says the same thing. But this is from an institution that actually believes in vaccines. So it wasn't put out by an anti-vaxxer. It was put out by somebody who expected the vaccine group to be the better, healthier group. And they tried to bury the evidence for a couple of years, and apparently now it's out. And of course, you don't hear about it on mainstream media because why? Mainstream media relies on pharmaceutical advertising, and they're not going to put it out there. So you won't hear about it, but you heard about it here. And you should look into it because you as a parent need to decide what to do for your children. And you young people who are listening, you're going to have children someday. You need to make the right decisions. And I can tell you with no joy in my heart that you cannot trust the modern obstetrical system. It is not there for your benefit. They can do miracles when you need it. But for the most part, and again, I always want to add that caveat, but for the most part, what they do has worsened outcomes for both mother and baby.
Well, thank you again for being so open to share all your information on your podcast and here. And we appreciate your seminar. You know, this is our second time trying to record because I had to cancel to go to a birth that ended up being a surprise breech. And, you know, when things went a little off, we knew exactly what to do, thanks to you. And we just really appreciate your knowledge.
Yeah, you don't know how that makes me feel.
Yeah.
Really good. Thank you.
Yeah. Well, thanks
Thanks, Sophia, for having me on.
Thank you for listening to our podcast. If you enjoyed what you heard, please rate, review, and subscribe. If you'd like to follow along, you can find us on Instagram at Born Wild Podcast and Facebook. You can go to our website at www.bornwildmidwifery.com. See you later.